Hey everybody, Dr. O here. Let's review the respiratory system. So some pretty straightforward ones here and some a little more complex. Where does the upper respiratory system end and the lower respiratory system begin? So this is important because people talk about upper and lower respiratory infections. The larynx. So the larynx is the beginning of the lower respiratory tract. So anything above that, so basically your sinuses, your nose, and your throat are going to be upper respiratory infections. Anything at the larynx and below would be classified as lower respiratory infections. So obviously you think there of pneumonia and bronchitis, these kind of things. So upper respiratory infections are way more common. Lower respiratory infections way more deadly. All right, so what is the larynx? The goal of your respiratory system is to transport and prepare air for the gas exchange surface of the lungs, also known as the alveoli. So that now the respiratory bronchioles do diffuse gases as well, but the crux, the majority of the gas transport in your lungs is at the alveoli. All right, what are the parts of the respiratory defense system and what do they do? So to me, the big ones are mucus, the mucus lining. And then we do have what's called the ciliary escalator, but you also do have immune cells. So you have macrophages that are in your respiratory system too. So the immune cells, they would engulf debris, engulf potential pathogens and let your immune system know what's going on. But mucus is very important because mucus is going to trap the dirt and dust and pathogens and whatever else is getting in. I mean, it's a huge opening. It's the, in microbiology, I talk all the time about this is by far the most common way we get sick is things entering our airways. So mucus is going to trap those things. The ciliary escalator, so hopefully you remember from our histology section, that you have the pseudostratified ciliated columnar epithelium. Well, the mucus is trapping this material. The ciliary escalator is going to carry it up out of your lungs, and then hope you're going to swallow it or expel it some way. So that's your respiratory defense system that's hopefully stops you most of the time, way more often than not, from getting sick when things are entering through your respiratory system. Respiratory defense system. All right, the function of the nasal conchae is to create turbulence in the nasal cavity. So the actual nasal conchae create the turbulence. The openings between them are called meatuses, and as air travels through them, it's going to swirl around. So which will take us to the next point. As the air swirls around in the nasal cavity, what three things are happening to it? It's being filtered by nose hairs, mucus, etc. It's being warmed up by the fact that your nasal cavity is warm. And it's being humidified. So air needs to be filtered, warmed, and humidified before it's ready for use, which is why it's better to breathe through your nose than your mouth. All right, so the nasal conchae create that turbulence, the swirling of the air. That's the reason for it. Those three things are happening to it. Okay, which laryngeal cartilage is larger in men than women? Hint, Adam's apple. So we both have it. It's thyroid cartilage, but testosterone during development causes the thyroid cartilage to get larger. The reason that's significant, so yes, there's an Adam's apple, but the main thing is it changes the size of the larynx and changes the tension and size of the vocal cords, which generally affects the pitch of the voice. So that is the thyroid cartilage is what we'd call the Adam's apple. Okay, what is the function of the epiglottis? So the epiglottis is an elastic tissue that fits over the glottis when you swallow. Now the glottis, so that's the next point. The glottis is the opening to your trachea. So when you swallow, there's three directions that food or anything else could go. So the epiglottis covers your trachea when you swallow so that food goes hopefully down your esophagus into the stomach. The third place it could go is out your nose, which is why when you swallow, your soft palate will elevate to hide that opening. So we'll talk about swallowing more in the digestive system, but that's the function of the epiglottis, to cover the glottis when you swallow so stuff doesn't go down the wrong pipe. Okay, what's the opening of the trachea called? We just said that. That is your glottis. So the glottis is the opening between the larynx and the trachea. What holds the trachea open? So the primary structural, the function of the trachea is to be open and to not offer resistance. You don't have to suck air through your trachea. So it has to stay wide open all the time. And that's going to be 15 to 20 C-shaped cartilage rings. Now where we're talking about is like lower cervical, maybe C5, C6 to the T5, T6 area. But so there's the trachea about a foot long or so. As it's traveling down, it needs to stay open. And these C-shaped cartilage rings are what hold it open. The reason they're C-shaped is because you actually don't want the cartilage rings behind the trachea because the esophagus is there. Imagine every time you swallowed, if your food was bumping down the trachea to do so. So the back of the trachea, there's a muscle, the trachealis muscle, and that does determine how big your trachea is. It does get smaller and bigger, but it does always have to stay open. The esophagus is closed unless you're swallowing, at least it should be. So it's those 15 to 20 C-shaped rings that hold the trachea open at all times. How many bronchi are there? So as we go from the larynx to the trachea, now we're in the bronchi. So we have primary, secondary, and tertiaries as far as we'll go. This tree keeps branching and branching and branching. But there are 2 primary bronchi, one for each lung, the right and the left. And we'll talk about why the right's different size. There are 5 secondary bronchi, one for each lobe. The right lung has 3 lobes, left lung has 2. So there are 2 primary bronchi, 5 secondary bronchi, and then I say 19 tertiary bronchi. And that's because this next point, how many bronchopulmonary segments are in each lung? So the tertiary bronchi goes to each one of these bronchopulmonary segments. There are 10, going to be 10 in your right lung and 8 or 9 in the left, but I just say 9. So if I ask you how many tertiary bronchi there are 19. So there are 2 primary bronchi, one for each lung, 5 secondary bronchi, one for each lobe, and 19 tertiary bronchi, one for each bronchopulmonary segment. All right, why is the right primary bronchus larger than the left? It's larger and more wide open because the right lung is bigger. It's got the heart's on the left side, so the right lung has the 3 lobes. But because of its shape and how it's aligned and how it's larger, that is why if someone's gonna have an obstruction of their airway, it'll be in that right primary bronchus versus the left usually. All right, why? I should proofread these. Why does the left lung only have 2 lobes? Well, that's because of the heart. So the right lung has a superior, a middle, and inferior lobe. The left lung just has a superior and inferior. Where the middle left lobe would be is where your heart is. So there's actually a little cardiac notch there where that middle lobe would have been. Clinically, that's important because if you're listening to the lungs, you have to remember that the right lung has that 3rd lobe. So kind of listening under the armpit's a good idea. So that's why the left lung only has 2 lobes. Sorry about the typo. All right, sympathetic activation causes, which opens the airways, would be bronchodilation. So when you activate your fight or flight sympathetic nervous system, it causes vasoconstriction. So that's what might confuse students. Causes your blood vessels to constrict, to increase blood pressure and change blood flow. Causes bronchodilation. You open your airways so you have more oxygen to fight or flee. So sympathetic activation causes bronchodilation. What is the function of surfactant and what kind of cells produce it? So surfactant, its job is to reduce surface tension. There's just tiny pressure changes inside your lungs, and to keep your lungs inflated, you need these pressure changes to be minuscule. But so you have to make sure there's not too much tension or pressure on your airways. So surfactant's job is to reduce surface tension so your airways don't just collapse on themselves. That if you don't have enough surfactant, that would cause respiratory distress syndrome, usually caused by being a premature baby, but it can happen in other situations too. So surfactant keeps your airways from just basically deflating on their own. What kind of cells produce it? They're called type 2 alveolar cells. So type 2, usually in Roman numerals, or I learned them as pneumocytes type 2, but type 2 alveolar cells is fine. All right, so reduce surface tension, and it's the type 2 cells that create it. This is why I should go back. So if a baby is a premature baby, the biggest concern is making sure their airways are ready. So they might use steroids and things like that to accelerate this development. Because once a baby's airways can function, they're not out of the woods completely, but way less likely to have serious damage if they're born prematurely. Okay, understand the pressure changes between the atmosphere and our lungs as we inhale and exhale. So the mechanics of breathing and these pressure changes are definitely not easy. But just let's try to make it as simple as possible. So your thoracic cavity, everything above your diaphragm is where your lungs are. So if I'm going to inhale, what happens is my diaphragm drops and my rib cage expands. That makes my thoracic cavity bigger, which means there's now less pressure in it. I just made it more roomy, so there's less pressure. So now there's less pressure inside my lungs than there is in the atmosphere. So things are going to move, down the path of least resistance, so they're going to move from high to low pressure. There's now more pressure outside of me than inside of me, so I draw air in. That's how I inhale. When I exhale, my lungs snap back into shape, my rib cage drops back down, my diaphragm pops back up. Now there's less space, so there's more pressure inside my lungs than in the atmosphere, so I will exhale. So tiny changes between the pressure inside your thorax and the atmosphere is what causes you to inhale and exhale. So don't overthink that. We just need tiny, couple millimeters of mercury, really, really tiny pressure changes are all it takes usually to breathe in and breathe out. All right, what is tidal volume, and what is the average amount of air moved during that tidal volume? So tidal volume is the amount of air we move during a normal quiet breath. So just sitting here, breathing, you and me, we should be moving about 500 milliliters of air per breath. So obviously, larger lungs, if you're more physically active, lots of things can affect this. But that's what tidal volume is. How much air do you normally move during a normal quiet breath? And the average amount is 500 milliliters. That's the only one of the volumes and capacities where I actually want you to know the number. All right, what is the most important respiratory muscle? That would be your diaphragm. So 75% of quiet breathing is caused by the diaphragm. So quiet, just a normal quiet, not a forced, I'm not sucking air in because I'm exercising. A normal quiet breath in, 75% of that is caused by the diaphragm contracting. The other 25% is my external intercostal muscles between my rib bones elevating the rib cage. So by far, it's the most common or most important respiratory muscle. Normal quiet, we'll talk about that actually in the next point. So what two muscles are involved in quiet inspiration? So I just said the two, the diaphragm and the external intercostals. Are there any muscles involved in quiet exhalation? So the answer is really no. A normal quiet breath out is caused by the relaxation of the muscles that breathe in and the tissues of your lungs. So if you're using muscles to exhale, you probably have a respiratory disease or like you're doing forced exhalation because you're exercising. So are there muscles that play a role in exhaling? Absolutely. If you're blowing a balloon or something, your abdominal muscles play a big role, the internal intercostal muscles. There are lots of muscles that can be involved in breathing, but with normal quiet breathing, it should just take those two muscles to inhale, diaphragm and external intercostals, and none to exhale. So we can get into the other muscles involved here at the next point. Is costal/chest breathing better or worse than diaphragmatic/belly breathing? Well, naturally we're supposed to be diaphragmatic belly breathers because the diaphragm should be the most important muscle. If you're a chest breather because of poor posture, you're sucking your gut in or whatever, you're going to involve a lot of accessory muscles, so like the muscles of the neck, your scalenes and traps, these kind of muscles, your pec. So I think that, your pec minor especially. So I think that chest breathing causes a lot of undue muscle tension here. So people that just always have tight necks and bad posture, I think that's hard on you. So we are designed to breathe from your belly. Ask any singing coach or anyone like that. So I do think that diaphragmatic belly breathing is better. Now, they obviously both can work. If you want to know if you're one or the other, I recommend laying on your back and putting a hand on your belly and a hand on your chest and just taking normal quiet breaths. That bottom hand should move about twice as much as the first. So if you want to practice that, if you want to practice what it feels like to be more of a diaphragmatic breather, breathe through a straw. That's what I always had patients do in the past. Okay, so I do think diaphragmatic/belly breathing is better. You can see why we don't do it though, because we suck in our guts all the time. All right, how do you calculate respiratory minute volume? This reminds me of cardiac output. Cardiac output is stroke volume, how much blood you move per beat, times your heart rate. How many times does it beat a minute? So your respiratory minute volume is your tidal volume, how much air do you move per breath, times your respiratory rate. How many times do you breathe per minute? So that tells you how much air you're going to move per minute. If the tidal volume is bigger, the respiratory rate will probably be smaller. And of course, it depends on if you're resting, etc. If you're exercising, your tidal volume is going to be really big. You're going to be moving lots of air, and you're going to be breathing fast. So you can move way more air per minute when you're exercising, just like we can move way more blood per minute when we're exercising as well. All right. What is the inspiratory reserve volume and the expiratory reserve volume? So like the names imply, reserve volumes, how much more can you inspire or inhale than normal? How much more can you expire or exhale than normal? So think about normal. I've just been sitting here breathing the whole time here. That's how much more I can inhale than normal. That's how much more I can exhale or expire than normal. Those are your reserve volumes. They give you the capacity to move way more air than you normally would need to. So if you want to know your vital capacity, the next point, take the biggest breath in you could and then blow it all out. How much air can you actually move? That's called your vital capacity. So let's get to that point. Why is the vital capacity of your lungs not the same as your total lung capacity? Well, that's because we can't control all the air in our lungs. So when I take a huge breath in and I blow it all out, my lungs aren't empty. There's this residual volume in the lungs that I can't exhale. And even then, there's what's called the minimal volume. Even if my two lungs would have both pop, right? If they were both to deflate, there would still be a tiny bit of air, just like when you take a balloon and let all the air out of it, there's still a little bit of air in it. So your vital capacity is the maximum amount of air you can control. You can move. Your total lung capacity is the amount of air that's in your lungs. All right, let's see here. Understand how diffusion of gases occurs at both the alveoli of the lungs and at a peripheral capillary bed. Can you follow a molecule of oxygen from the air you breathe until it reaches a cell? Can you follow a molecule of CO2 from the cell it was produced at until you breathe it out? All right, so obviously big question, but let's start with diffusion. Diffusion is the movement of solutes from high to low concentration. So think about the concentration of oxygen and carbon dioxide in your lungs and the concentration of oxygen and carbon dioxide in your tissues, and that'll help. So let's start with the molecule of oxygen. It's entered your airways. It's now in the alveoli of your lungs. This dirty oxygen poor blood just showed up from your pulmonary circuit. It's got a lot of CO2 in it. So the high level of CO2 in that air or in that blood is going to cause CO2 to diffuse out. The high level of oxygen is going to cause oxygen diffusion. So now I'm a molecule of oxygen. I've entered the circulatory system. I'm going to go back to the left side of the heart, the systemic circuit. I'm going to be pumped through the aorta somewhere, right? So whether it's my liver, my spleen, my pinky toe, doesn't matter. When I reach that capillary bed, there's now more oxygen in the blood than there is in those tissues. So as oxygen, I'm going to diffuse out. So oxygen diffused into your blood and hopped on hemoglobin, was carried somewhere where it's needed, and since it's needed there, it's going to hop off. So it's going to diffuse into your blood and then out of your blood. CO2 is going to do the exact opposite. The levels of CO2 at your peripheral tissues is higher, so it's CO2 is going to jump into your blood there, be carried back to your heart, back to your lungs, and jump out there, so you can exhale it. So they do the exact opposite. Well, I was just going to get into how it's carried, but that's going to be the next question here. So, how is most of the oxygen in your bloodstream carried to and fro? That's actually not a typo. I meant to say that. How about carbon dioxide? So almost all of the oxygen in your bloodstream is carried on hemoglobin. So hemoglobin is designed to carry oxygen. 98, 99% of the oxygen in your blood is being carried on hemoglobin. So hemoglobin that's picked up on oxygen, just to review these terms from an earlier chapter, would be called oxyhemoglobin. When it's dumped off its oxygen, it's called deoxyhemoglobin. And then you'll see in just a moment, there's another type of hemoglobin that's picked up CO2 called carbaminohemoglobin. So how is most of the oxygen in your bloodstream carried to and fro? It is on hemoglobin, almost all of it. How about carbon dioxide? That's going to be a little different. So let's start with the plasma. Only 7% of carbon dioxide is carried right in your plasma. It dissolves right in the plasma. It's not carried really by anything, just the water of your blood. The huge majority of carbon dioxide, 70%, is carried as carbonic acid. So it's important to remember, carbon dioxide becomes a weak acid. That's a huge deal when we talk about acid-base disturbances. It's a huge deal when we talk about the fact that the most common acid-base disorders are called respiratory acidosis. It's because your breathing rate changes, and then that leaves this acidic carbon dioxide around, and it affects your body and can be fatal. So 7% of carbon dioxide is carried right in the plasma, 70% as carbonic acid. The other 23% is carried on hemoglobin as carbaminohemoglobin. But the big one there by far is the carbonic acid, 70%. All right. Which of the above two gases has to be the most tightly controlled? That's carbon dioxide. We have tons of oxygen. Every red blood cell can carry over 1 billion molecules of oxygen. We've got boatloads of it around. That's how we can survive it, higher than sea level, etc. So we have extra blood. We have a venous reserve of blood. We've got lots of oxygen. Not saying it's not important, but your body's much more interested in your carbon dioxide levels and your pH than it is oxygen. So carbon dioxide is the answer there. The chemoreceptors in the pons, which we'll get to in just a moment, they're see how I think through this thing the same way I made the review. They're looking at carbon dioxide levels. If your CO2 levels get too high, they're going to tell you to breathe faster to get rid of it. If your CO2 levels get too low, it's going to tell you to slow down your breathing so you can keep more of it. Okay. What part of the brain controls breathing? How about rate of respiration? So there are two answers there, which I covered in the brain section. The medulla oblongata controls breathing. That's called your respiratory rhythmicity centers, the part of the brain that just says breathe in, breathe out, breathe in, breathe out. But the rate of respiration is controlled by the pons, and it's primarily looking at CO2, like I just said. It says breathe faster or breathe slower based on your needs. Okay, what effect does hyperventilation have on your blood gases? How about hypoventilation? Again, this will be a much bigger deal when we're talking about acid-base disturbances. Hyperventilation is going to lead to respiratory alkalosis. The pH of your blood is going to climb too high. So blood pH is normally 7.35 to 7.45. If you're breathing too fast, you're blowing out too much carbon dioxide. You're getting rid of too much of that carbonic acid. So now you've removed some acids, so the pH will climb. So if your pH gets above 7.45, you now have respiratory alkalosis. So when you're hyperventilating, or if you see somebody hyperventilating, what should you do? Have them breathe in a bag. They usually say a paper bag. Have them breathe in a bag. You actually want them to breathe that carbon dioxide back in. They're getting rid of too much of it. So everyone knows to breathe in the bag, but that's why. And if not, get them comfortable because they're going to pass out. Hopefully when they pass out, their breathing will normalize and they'll be okay. So hyperventilation, you're getting rid of too much carbon dioxide. So that's why you have them breathe in a bag. Hypoventilation is the most common cause of respiratory acidosis. You're breathing too slow, there's too much CO2 in your blood, too much carbonic acid, and your pH will drop below 7.35. So respiratory acidosis is the most common acid-base disturbance. Some students will say in other classes they talk about metabolic acidosis. I would say metabolic acidosis is the most common cause of an emergency as far as like somebody in the intensive care unit, these types of things. But overall, the most common acid-base disturbance is respiratory acidosis caused by hypoventilation. Why would that be? There are a lot of drugs that slow breathing, lots of types of brain issues that slow breathing, but mainly lung diseases. If you have COPD, asthma, chronic asthma, emphysema, these things are going to cause hypoventilation too. All right, lastly, what is a pneumothorax and atelectasis? So these terms get used interchangeably and they probably shouldn't. Pneumothorax is the damage. So if you're in a motorcycle accident or you get hit, something, pneumothorax is the damage that separates the visceral and parietal pleura, the layers of membranes outside the lung. That causes the pressure change that collapses the lungs, but a collapsed lung is the atelectasis. So pneumothorax is really the damage or trauma that separates those two layers of the pleural cavity. The collapsing of the lung is called atelectasis. Okay? All right, hopefully you can see that. My head wasn't on the way there. All right, that's the respiratory system. Be blessed and have a wonderful day, guys.